Hi everyone. So let us discuss FMG July 2025 question. There were like 7 questions which I got, and they were all from the expected topic and the topics which we had already covered in all our quick revision, main videos, and even in the most important question, because they are the questions which are from the topics which are always being asked in FMG exam. So the first, as I said, I always say that in anesthesia, if you just ask me one topic I want to read, I would say malignant hypothermia. So malignant hypothermia is favorite topic of exam, and this is the question which has been asked. Malignant hypothermia, mutation of RYR1 receptors, that is ryanodine receptor, leads to deadly reaction to anesthetic agents. What is the ionic abnormality? So they had asked about the pathophysiology of malignant hypothermia. So I always teach that in malignant hypothermia, it's a pharmacogenetic disease when someone has a particular gene, and if they're exposed to some anesthetic agent, it gets triggered. And when it gets triggered, the sarcoplasmic, there's a massive calcium release from sarcoplasmic reticulum, and this increased calcium release causes the metabolism of the patient to become twice, thrice the normal. And all the clinical features because of this metabolic storm which happens in the body. So this time they had asked about the ionic abnormality, right? The first line which we used to discuss. And the answer is the calcium release from sarcoplasmic reticulum. So malignant hypothermia, again and again, I am saying this is a favorite topic of exam. It is, as I said, it's a pharmacogenetic disease. Pharmacogenetic disease. So what is the reason for malignant hypothermia? Because of the gene present in an individual. If the person is exposed to certain drug, what happens? The malignant hypothermia gets triggered. So exposed to certain drugs like your inhalational anesthetic. This has been asked so many times. Halothane, isoflurane, sevoflurane, they trigger malignant hypothermia. Succinylcholine. So this is a depolarizing neuromuscular blocking agent which trigger malignant hypothermia. These are the two major drugs which trigger. So if they're exposed to these drugs, the gene gets triggered, and this causes intense release, the massive release, I say, of calcium from sarcoplasmic reticulum. Sarcoplasmic reticulum. And what does it do? When this intense calcium release happen, this causes metabolism to double to triple. So this is a hypermetabolic state. So because of hypermetabolism, what would be the clinical feature? There would be byproduct of metabolism getting released. So increased carbon dioxide, increased blood pressure, increased heart rate, arrhythmia, increased core temperature. All this will happen in malignant hypothermia. And because of the storm of metabolism, cell breakdown, renal failure, patient will go into renal failure. Death would be certain if not managed immediately. So what is the treatment? The treatment is a drug of choice of malignant hypothermia is dantrolene. So dantrolene is the agent of choice. This is the antidote. Antidote. What does it do? Stops the calcium release. Stops calcium release. So it stops the very cause of malignant hypothermia, which is happening due to the calcium release. So this was a very simple question from a very expected topic. The day-to-day thing which we talk, the question was on that, right? Okay, the next question. Again, I have very particularly talked about this in airway, that what we do when we cannot intubate and we cannot ventilate the patient. So this is a patient after maxillofacial trauma. So patient had a maxillofacial trauma, and patient was not able to intubate it. So this is an acute emergency. Patient was not able to intubate it, and maxillofacial trauma patient, the patient was not able to ventilate also. So intubate, cannot intubate, cannot ventilate. So some student says in the question it was clearly written cannot ventilate also. Even if it was not written cannot ventilate, it's a maxillofacial trauma. We are thinking that ventilation is also very difficult. So it's a condition which I always say that it's a SICO, cannot intubate, cannot oxygenate. And whenever we see SICO, we do only one thing, cricothyroidotomy, right? So emergency cricothyroidotomy should be the answer in this case. In maxillofacial trauma, you never put the nasopharyngeal airway. Nasopharyngeal airway is not put in. It is contraindicated. In laryngeal mask airway would also not go at the right place. In maxillofacial trauma, we can try, but it is not something which would easily go in the place, right? And in case of cannot intubate, cannot ventilate situation, well, the time is what we have to do. Immediately, we have to start the oxygenation. So, cricothyroidotomy would be the best thing. And bronchoscopy is out of question, right? Even laryngeal mask airway is not apt for this situation, right? So, I talked about difficult airway management. Difficult airway management. In difficult airway management, I said that whenever we are not able to intubate, not able to intubate, this is what is difficult airway, right? So whenever this happens, what do? We try to ventilate by bag and mask. Ventilation, ventilate by bag and mask. So when we try to ventilate by bag and mask, what happens? The oxygenation we can do. If this is a way, this we are able to ventilate, then we go for the step 2. And in step 2, what do we do? In step 2, we go for insertion of LMA. So we use LMA. If we are able to ventilate, if we are able to ventilate. If we are not able to ventilate, bag and mask ventilation is also not possible. Cannot intubate, bag and mask ventilation is also not possible. This is cannot intubate, cannot ventilate situation. This is cannot intubate, cannot ventilate situation. And this is very common situation in maxillofacial trauma, etc. When intubation becomes difficult, ventilation is also already very difficult. So in this case, immediately what we do cricothyroidotomy. Cricothyroidotomy, right? In cricothyroidotomy, what we do, this is a thyroid cartilage, right? This is cricoid cartilage, okay? And this is cricothyroid membrane, and this is the trachea below this. What we do, we put a needle in cricothyroid membrane and have an access to the airway. This is a temporary access, and this will help us in oxygenation of the patient. This can be done by eating a simple needle, or even we can go for a surgical cricothyroidotomy by a cricothyroidotomy set. So this is cricothyroidotomy. I always tell. Remember, even if the tracheostomy was in the option, if it's an emergency, we have to do cricothyroidotomy. Tracheostomy cannot be the answer. In emergency, we have to do cricothyroidotomy. Tracheostomy is an elective procedure. It will take time and it is always done in a stable patient, right? So answer has to be cricothyroidotomy. Okay, next question. Now, there was an arrow on this and they asked, what is the use of this structure in this device? So we always talk about the endotracheal tube and your tracheostomy tube. And I tell you about this cuff. What is the use of this cuff? Now, this cuff has two major use. Number one, that when we insert the device, whether it is endotracheal tube or it is a tracheostomy tube, it's a tracheostomy tube. Whether it's an endotracheal tube or it's a tracheostomy tube. You are getting my point? If we have put a hole in trachea and inserted a tube, or it's an endotracheal tube. If it has cuff, what does it do? If it has cuff, what does it do? It creates a seal in trachea. This is creating seal in trachea. Seal in trachea. This is creating seal for giving us a proper seal for positive pressure ventilation, creating a seal for positive pressure ventilation, and also to prevent aspiration. This seal is preventing any oral secretion to go in the respiratory tract. So let's see the option. Used to prevent aspiration, okay, for ventilation. Now, this creates a seal which is necessary for ventilation, but this device, this cuff is not something what is used for ventilation. So it creates seal for ventilation, but it is like it is not something with which we ventilate. So better answer for this question would be used to prevent aspiration. If in the question it was to create a seal for ventilation, to create seal for ventilation, if this was there and both were in the option, and both, let's say it was like both is correct, then I would have gone for both is correct, right? But in this case, used to prevent aspiration would be my answer, because for ventilation, the seal is required to create, the cuff is required to create a seal for ventilation. It is not used for ventilation. Got it? So used to prevent aspiration would be the answer. To prevent displacement of tube, this is completely wrong. Now, even if I inflate the cuff and pull the tube, it will come out. So it is never helpful in keeping the tube in the place. Okay. So it is used to prevent aspiration. Remember, the use of the endotracheal tube and the tracheostomy tube is what? Number one uses, one of very important uses to protect the airway from aspiration, to protect airway from aspiration. And for to protect the airway from aspiration, both the device has been provided with this cuff. The cuff which is used most commonly is high volume, low pressure cuff, low pressure cuff, high volume, low pressure cuff. And the pressure which, I mean, the seal, the pressure seal which we need to prevent aspiration is your 25 to 30 centimeter of water or 18 to 24 of Hg. Now, this is what is the pressure required to prevent aspiration. So this is the pressure to prevent aspiration. And the most common cough is high volume, low pressure cough, right? And this is to protect the airway from aspiration. And also to create seal for positive pressure ventilation, to create seal for positive pressure ventilation. But it is not used for positive pressure ventilation, right? So answer has to be to protect the airway from aspiration. That's the major role. Okay, next question. Again, an image-based question. This image was given in the exam and there was a marking on the numerical value beside that image, right? And they asked, what is the mark structure measure? What is this mark structure measure, right? Okay. Now, this is a graph of Capno, so you have to recognize the graph of Capno. And what does it represent? I told you, it represents the end tidal carbon dioxide. So answer is EtCO2. So I always tell in monitor, what is the normal graph and what is the value between that graph can be can be asked in exam, and see, it has been asked in exam. So till here everything is what we have discussed, nothing is out of context or no new question I'm seeing, right? So it is Entidal CO2. Okay, so if I see the monitor, this is, let's say, the monitor screen. Okay, now the first graph which comes is your, let's say this is the ECG graph, although I have made a VF kind of graph, but this is, let's say, ECG graph. Beside that is your, let's say, the 72 written. What does this represent? This represents heart rate, heart rate. Then we have this, let's say, pulse oximetry graph, pulse oximetry graph. Beside this is 98 written. What does this represent? This represents oxygen saturation of arterial blood, oxygen saturation of arterial blood. And then we have this capnograph, capnograph. And beside this written 35. What does it represent? This represents end tidal carbon dioxide, end expired carbon dioxide. Normal value is between 35 to 45. And then it is written here 109 by 80, 109 by 80, right? And even a mean blood pressure is written. So this is systolic, this is diastolic, and mean blood pressure. And here the temperature would be of the patient would be written. Okay. Now these are the mandatory monitors, that is ECG, pulse oximetry, capnography, NIBP, and temperature probe. On every monitor screen, this will be there. And this is something very commonly asked. What is the mandatory monitor? What are the normal graphs? What are the normal value? And see, it has been asked in exam. So answer is end tidal carbon dioxide. EtCO2 stands for that. Okay, next question. Again, daycare surgery and ERAS, both are being asked in exam. So both are important. So I'll tell you, a man has to undergo laparoscopic appendicectomy or cholecystectomy, whatever was in the exam. I mean, I got different kind of answers. In daycare, daycare means the patient is admitted on the day of surgery, operated on the same calendar day, and discharged on the same calendar day. So patient is not an inpatient, not admitted patient. So there are certain criteria to choose the patient for this kind of surgery. And a lot of procedures are undergoing on the daycare basis. And we modify a little bit our anesthesia plan to facilitate the daycare surgery. So which of the following is contraindicated for daycare surgery? So for daycare surgery, which is not the criteria patient meets? Living 40 minutes away from hospital, well, If patient can come to the hospital within an hour from where he resides, that's we can take that patient for daycare surgery. Okay, general anesthesia for less than an hour. Again, it's not a long duration surgery. We can take this patient for daycare surgery. Patient without an attendant at home. Now, if there is no person to look for after the patient when we discharge the patient, when the patient goes home, this is a strict contraindication for daycare surgery. So this is what is should be the answer. Patient with ASA grade 3. Patient with ASA grade 3, if it's an optimized patient, we can take for daycare surgery. 3 and 4, we are little skeptical. We have to thoroughly investigate, thoroughly, let's say, evaluate our patient. But if a stable grade 3 patient, we can take the patient. ASA grade 3, we can take the patient, right? So answer is patient without an attendant at home. So let us very quickly see the reasons for precluding, reasons for not taking a patient for ambulatory surgery. Ambulatory means daycare. Ambulatory means daycare surgery. So these are the reasons if patient fails to meet these requirements, we don't take the patient for daycare surgery. What are the surgical consideration? If it's an emergency surgery, patient is not a optimized patient, so that patient cannot be operated on daycare basis. Patient has to be admitted to hospital. So emergency surgery. Surgery should not carry any significant risk of major consideration. Now, not third space fluid loss, not major blood loss happening during surgery. If any such surgery, we have to get the patient admitted. So surgery with minimal complications, right? Not something which is obviously can happen in surgery, a great blood loss or third space loss, etc. Now, surgery should not be of very long duration. So surgery should not be of very long duration, right? Surgeons with enough experience to perform the procedure, yes. If it's a naive surgeon, then they can make a complication. Again, daycare surgeries, we always see the person who is operating, that the person should be an experienced person, right? With a less chance of creating any new complication in the patient. Yes, right? Okay. So these are the surgical consideration or social consideration. Patient cannot be accompanied by a responsible adult to take care in post-op period. Patient having no attendant, patient with no access to any emergency service within an hour of discharge. So patient is going to some remote location, then we cannot discharge that kind of patient. Patient should come wherever he is within an hour if any emergency happens. Patient with possibility of loss of follow-up, where patient we may not follow up, no phone connection or something like that. Again, we if I am getting a patient operated on daycare, I have to take care that I can contact with that patient in case of any emergency. Patient's home environment not suitable for postoperative care, right? So home environment has a very big role in choosing a patient for daycare surgery. If someone has no home care, we cannot take that kind of person for daycare surgery. Then medical consideration, patient with unstable, the word is unstable medical condition, basically ASA grade 4, right? Like angina, inadequately controlled diabetes. Functional status of the patient, poor. Patient has a very poor functional status, effort tolerance less than 4. Patient has a MET level less than 4. So I talked in our main video about MET level, which tell us about the functional status of the patient. And we have to be very cautious in patient with ASA grade 3 and above, right? But if they are stable, we can take. We have to be cautious, but it is not a contraindication. It's not a contraindication. So answer has to be patient without an attendant at home. Okay, next question. Now again, an image-based question, or some student says image, some says it's just for a single line of question. That trainer for monitoring is used on which nerve? Or image was given, which is the most common nerve used for monitoring? Well, I told you for neuromuscular monitoring, image, without image, whatever, answer is alert, alert, alert. So always alert. So again, the answer is alert, right? I appeared for my PG, they asked the exam, which is the most common nerve monitored during GA? That was not a good question. During GA, very, let's say, weird kind of question. For what we are monitoring? They had not mentioned in that. Answer was ulnar nerve. Then the question was a little more specific. For neuromuscular monitoring, which nerve is used? Ulnar nerve. Then image, which nerve is being monitored? Ulnar nerve. Always ulnar nerve. So answer is ulnar nerve. Got it? Okay, next question. Narrowest part of adult airway. So I always talk about the airway. Then in that, I talk about a little bit about the anatomy of the airway, and I tell you, in adult, and pediatric airway, we have little difference. And in adult, the narrowest part is your glottic opening. The narrowest part is glottic opening, right? And in pediatric, the narrowest part is subglottis, or we call it cricoid. So again, a very simplest question. So in adult, not even in pediatric, they had asked. In adult, it is glottic opening. In pediatric, it is subglottis or cricoid. So answer would be the glottic opening. That's why in adult, we always put a cuffed tube so that when we see the tube crossing, the cuff crossing the glottic opening, it will not cause trauma anywhere else. And in pediatric, for a certain age group, we use uncuffed tube because uncuffed tube can impinge at subglottic level. I mean, cuffed tube can impinge at subglottic level and can cause subglottic edema. So uncuffed tube is preferred for very small children because of cricoid or subglottis being the narrowest part. So this was another question. Okay, now let's see the next question. Okay. In paroxysmal supraventricular tachycardia, which of the following drug can be used? So I didn't get all the answer of all the drug, but again, I told you, 4 flow chart is very important for the emergency care of the patient. One is the tachyarrhythmia management chart, then bradyarrhythmia management flow chart, then BLS flow chart and ACLS flow chart. Each and every word of these flow chart is important. And in all my lecture, I provide students with all these four flow charts. And you have to just memorize each and every point of these flow charts. So here the question was, in PSVT, which of the following drug can be used? Well, PSVT is supraventricular tachyarrhythmia, isn't it? Paroxysmal supraventricular tachyarrhythmia is supraventricular tachyarrhythmia. And for supra PSVT, that is the reentrant pathway has been formed and repeatedly the AV node is getting stimulated. So we are getting a tachyarrhythmia. We are getting a narrow QRS complex tachyarrhythmia, narrow QRS complex tachyarrhythmia, right? And heart rate is very high. Heart rate is more than 170 beats per minute, right? Then P wave is not seen. P wave not seen, right? QRS is narrow. So this is PSVT. Now, the first thing in management of PSVT, we do the vagal maneuver. First thing is vagal maneuver. And in vagal maneuver, 25% of the PSVT respond to it. If patient doesn't respond, then we can give adenosine. Adenosine is the drug of choice in PSVT. We start with 6 milligram. We can go to 12 milligrams, the second dose, and we can go to 18 milligram. So this is the AV nodal blocking agent. So they delay the AV node and decrease the heart rate. So adenosine. If patient does not respond to adenosine, then we can go for beta blocker or calcium channel blocker. They will control the ventricular rate. Calcium channel blocker, right? So they are all AV node delaying drug. So they will control the ventricular rate. So beta blocker or calcium channel blocker. They are These are the most common drug used for treating PSVT, but we can also use antiarrhythmic. For PSVT, we can also use antiarrhythmic. So antiarrhythmic can be used for PSVT, and the commonest antiarrhythmic which is used for PSVT is amiodarone. Amiodarone. You know, guys, I always tell to my students, this is the best antiarrhythmic with having effect on all the channels of heart. Now, it acts on calcium channel, it acts on sodium channel, it acts on potassium channel, it acts on every channel of the heart. So overall, it stabilizes the heart, right? So amiodarone is one just good drug, good antiarrhythmic. So it can be used, okay? So answer is amiodarone. Amiodarone is the answer. So these were the 7, 8 questions which I got. So very quickly, again, I will revise the questions for you. So in PSVT, which of the following drug can be used? Amiodarone. The drug of choice, if it would have been asked, and adenosine would have been in the option, we would have marked adenosine. But which drug can be used? Answer is amiodarone. Okay, amiodarone. Okay, next. Narrowest part of adult airway, glottic opening. Next, Which of the following most commonly used for nerve for monitoring, neuromuscular monitoring, or image-based question, which nerve is getting monitored? Answer is unlearned nerve. Next question. A man has to undergo laparoscopic appendectomy or cholecystectomy on daycare basis. Which of the following is contraindicated for daycare surgery? Which is not, if patient does not have that, which precludes daycare surgery. Okay, the patient without an attendant at home. We cannot take such patient for ambulatory or daycare surgery. Okay, then image-based question again, graph was given and marking was on the numerical value. And what is this? End-tidal carbon dioxide. The answer is end-tidal carbon dioxide. Okay. Then what is this structure used for? It is used to prevent aspiration. Okay. Okay. After maxillofacial trauma, patient cannot be intubated. What is the immediate next step? Emergency cricothyroidotomy. Because this is cannot intubate, cannot ventilate situation. Always the answer would be emergency cricothyroidotomy. Okay. Okay, next question. Malignant hypothermia, mutation of ryanodine R1 receptors lead deadly reaction to anesthetic agent. What is the ionic abnormality? Answer is calcium release from sarcoplasmic reticulum. So these were the 8 questions which was asked from anesthesia, and all 8 you must have done correctly, I know, right? Because these all 8 are expected questions. So again, the points which we are trying to prove, questions are from the expected topic. You just have to improve your accuracy to give best result. So if you had a good accuracy and good grip on PYTs, these questions you could have solved easily. My best wishes for your result. Thank you.